So the starting point, back when I had hair and the trustees were really thinking about starting research in the UK into SCAD, if we only really have to go back maybe 5 or 8 years, and SCAD research is in the world of anecdote. It's about single patient descriptions in the medical literature. That's really all that there is. And we do owe an important debt of gratitude to the amazing SCAD research team at the Mayo Clinic and also in Vancouver in Canada, who really started the process of actually realizing that SCAD is not actually a terribly rare condition, as we're starting to see in terms of the people in the room, the number of people on the Facebook page. It's not a common thing, but it is quite a significant condition, which is, it's definitely out there, and we all bear witness to that. In terms of what we've been doing in the UK, essentially we've been building up over time, and it is financially dependent. We initially started with some funding from the British Heart Foundation, but in the last few years we've been supported really by Beat SCAD predominantly, and I've sold a kidney and all of that kind of stuff to keep the research ticking over. But we are making really quite important progress, and this is a really critical year for the research, and I think it'll be really nice when we get to conference season in June, because I think there'll be even more coming out. So this year, obviously, many of you will be aware we published the first gene associated with SCAD, and I think before the conference there'll be a whole bunch more. And a lot of the genetic research that is being done is down to people who have been giving their blood samples even when they've come to the clinic, or you've received the grey box of doom in the post with the please go and find your doctor to go and get a blood sample checked. So we have now, with the help of an industrial partner actually, sequenced the whole genome of 400 SCAD survivors. That's a really big study in the world of SCAD. And where we're at the moment is we're looking through all of those genes. It's a large amount of data. And we're learning all about these different genes. There are different types of genes. Some of them that are risk factors. So the one that was published at the beginning of this year, Factor 1, it's a bit like a risk factor. So it increases your risk a little bit. It's not something that runs in families, in a sense, not like a Duchenne muscular dystrophy or something like that, where if you have it, your children will get it. It's not that kind of gene. It's more of a risk factor, and we call it a common variant. But the interesting thing about that gene is it's also a risk variant for fibromuscular dysplasia, which we know has this association with SCAD. It's a risk factor for carotid dissection, a risk factor for migraine, which we see very frequently in the SCAD population. And also, interestingly, it's slightly protective against the more conventional type of heart disease, the atherosclerotic, the cholesterol type heart disease. So like a lot of genes, it has its pros and its cons. And I think we're working very closely with international partners, with the Mayo Clinic, with the big French group, and also with the Australians on different aspects of the genetics. And there's going to be lots more both common genes and rare genes that we will understand. I think it's important to say this. At the moment, there is no evidence from the research that we've got so far to say that SCAD is a strongly familial condition, that it runs in families, okay? We need to finish the research studies, but again, at the moment, we don't feel that we need to genetically screen families of patients who have SCAD. But we need to finish this, okay? So there's a lot more to be done, and there'll be a lot more to learn about, okay? There are also, that we're doing at the moment, what we call biomarker studies. So for example, wouldn't it be nice if when somebody comes in as have you had a SCAD type of patient who arrives, that we could do a blood test and say yes or no, or high risk or low risk. And that's something that we're working with collaborators in Spain at the moment, looking at the samples from some of the patients who've actually come to my centre with SCAD to see, can we build a profile of blood markers to help with an early diagnosis. We're also looking at all of the blood of patients who've given samples at the moment, again, to see is there any factor in the blood which distinguishes between patients who've had SCAD and and we should also acknowledge this, all of our wonderful healthy volunteers who act as our control. So it's brilliant that we have all of our SCAD survivors helping to contribute to the research. Also, we are massively grateful for all of those healthy volunteers. There is no female relative of mine who hasn't been dragged into Leicester, forced through a scanner, given an armful of blood. And it's brilliant that they do it, because otherwise we have no comparison against which to make these judgments. So there's lots going on at the moment, working on the blood samples, the skin biopsy samples that some of you have given as well. They are being grown up, and we're working very closely with a group, a fibromuscular dysplasia group in New York, who have been looking at these, the fibroblasts and fibromuscular dysplasia patients and SCAD patients. So that's all a lot of ramble, but essentially what it is it's about doing the things to try to understand at a genetic and a molecular level what constitutes a risk. Why does somebody get SCAD and somebody else doesn't? And those are the key things to starting to help us try to understand the mechanisms behind the process, and obviously that then helps us to start to think about how you might change those mechanisms in a favourable way to reduce risk. So, lots of things going on, and hopefully that will emerge this year. Quite a lot of, data that I'm looking at, which is very exciting in a preliminary stage. All of these things have to be validated and compared. We often want the answers sooner, of course we do, but it has to be done right, and of course we are a small team. So we are beavering away as hard as we can to get the answers for you, but we have to do it right and take the time to do it properly, can get our international partners to validate the things that we find, because if, as with the FACTAR1 gene, for example, the fact that we found it in the UK, but our French colleagues, Australian colleagues, and American colleagues were then all able to validate the same gene, means it's real, as opposed to, we just found it in our population, if that makes sense. So that's an important paper that was published this year, and also a body of work that's moving forward in the research. The other important paper was a more mechanistic paper. It's based, so there's a picture behind me kind of thing, as to actually what happens at the time of SCAD. And this is where, when you sign up online and to agree to participate in the research, many of you will fill in the questionnaires. Those questionnaires are really important for us. That's a big treasure trove of data that we're using. But also you sign your permission to allow us to get access to your medical imaging and the data from the time that you have your SCAD. And that's, again, a sort of treasure trove of information and data that we are using. And what we've been doing, and what we published earlier on this year, is a study of the imaging that was taken from the inside of the coronary arteries of patients like yourselves having SCAD. We published a series of 60. The previous largest published series was 8, which gives you an indication as to how much more power the study has when it's bigger like this. And the critical finding from the study was both something, well, there were several critical things. First of all, it was advice for the doctors that are doing the interventional procedures about how to do it safely, which is important, but also it helped us to understand a bit more about what is going on here. And what the study showed is that when you look at the images and do very careful measurements, that if you remember, if you think of a coronary artery as a tube, and I say that it's a tube that has a thickness in the wall, so it's like a tube with a tire. And what happens in SCAD is you get a bruise or a bleed inside the wall. There's been a lot of question as to how does the blood get there? Does it come from the inside and then go out like this? Or does it actually start from the outside and then maybe even come back in? And the work that the guys did on this for me when they were looking at these images essentially demonstrated that when there is no connection between these two areas, that this area, the false lumen we call it, was pressurized. So it was forcing the artery outwards, squashing the lumen inwards, and was bigger. And this little bit here between the two was thinned down. And what all of these things suggest to us is that the first part of the process is the development of the bruise, which becomes pressurized and tense, and it may then be a secondary effect that the bruise may, if you like, or the bleed in the wall may actually rupture back into the lumen. And these again are important mechanistic understandings, because we have to try and think about what happens to cause the bruise to develop. And obviously we're starting to focus a little bit more on the little tiny blood vessels in the wall of the artery, and whether they could be something that might be vulnerable in SCAD, at the time of SCAD as the source of the bleeding. So these are all incremental steps forward. Other things, some of you will have been through the MRI scanner. So the first of the papers from the MRI scanner is currently with the journal reviewers. If you know any of them and could, give it a good, give them a nudge for me, that will help us out. What that paper shows is that in the majority of SCAD patients, the injury after SCAD is small. In many patients, in fact, a significant minority of patients, there is actually almost no detectable heart muscle injury after the heart attack. So that's good news for SCAD patients in a sense. You will always get a spectrum. So there will always be some patients who are more severely affected, and it was mentioned before, the pregnancy-associated SCAD does seem to have that slightly more aggressive phenotype that we've identified. But it's also important in terms of looking at recurrence, which is something that we are all anxious about naturally. Okay, the first thing about recurrence, and I say this to people when they come and see me in clinic, is to remember that yes, there is a recurrence risk, and the data on recurrence at the moment suggests something around a 10% risk over a 3 and a bit year follow-up. And we don't have the long follow-up data, but it probably ebbs away to some extent after that. But if you flip that on its head, it's a 90% chance that that's not going to happen. So we have to try and keep that risk in proportion. And I think Bex and others have been talking eloquently about trying to make sure that yes, we behave appropriately and react appropriately, but also we don't let those things become too big and allow us to continue in terms of our lives moving forward. But also what the MRI scan showed is that if you were unlucky enough to have a recurrence, 1 or 2 in the room may have been unlucky enough to have a recurrence, that again the outlook in terms of the heart injury is generally speaking good. So those are again helpful things to understand. We know that the event itself is a high risk situation, and that's why you have to be in hospital. But the long-term outcomes, if you can get through that, is a good thing. So that's one bit of the research. We're also looking at the rest of the arteries in the body. That's a job of work. So those of you again who've been through the MRI and the CT scanner, we'll be hoping to publish data on that. I think before Christmas we will hopefully have that out. So there's a whole bunch of things that we're working through. In terms of how the research works at the moment, we have the amazing resources provided to us by BeatSCAD, but we are a small team. We are me and we are Alice. So we are not a big team, so we have to work through all of these studies that I've talked to you about now and try and keep on top of everything and try and move things forward and get to a conclusion. What that means is that we have to pick and choose the bits that we can do at a particular time. So at the moment, we're focused on some of the things that we've said. Also, Alice is focusing particularly on men who've had SCAD at the moment, people who've had recurrent SCAD. So there'll be little areas of focus and there'll be little calls. So one of the things that we are doing right now is sending out all of those questionnaires again to say, all of the follow-up. It's not the long one. If you haven't done the long one, please do the long one. But if you have done the long one, this is the shorter follow-up questionnaire, because again, we need to know, for those patients who registered 5 years ago, how you're doing. We need to know about that so that we can understand that. And again, when we can put all of the outcomes and the data in context. So that's a flavour. I can ramble on for many more hours on the different elements of the research, but there's a couple of people falling off their chairs at the back. So I'll move on quickly and just talk about the clinical stuff. So, as you know, we like to provide clinical support for patients with SCAD. We believe or hope that by, if you like, providing a clinical service as a small group of clinicians, or very small at the moment, in terms of me and Alice, and Abby a bit, but we think it is very useful for patients to come and see someone who sees lots of people with SCAD. It's not necessarily because we have all the answers, because as you know, there are still lots of questions for which we don't have clear answers, and that's the driver behind the research. But what we do have is quite a lot of experience of looking after lots of SCAD survivors, understanding a bit about what the experience after SCAD is, some of the challenges with medications, some of the things which arise, and so on and so forth. So, you know, we are keen to try to maintain that service if we can. We want to acknowledge and, you know, and boost and support the Beat SCAD team, who have been doing a huge amount of work in the principalities in Scotland and Wales, also in England, to try to promote this. Because what we really need for SCAD is to be recognised as a specialist clinical service. As a community, what we should be ultimately aiming for is to have 2 or 3 SCAD specialist centres in England. 1 in Scotland, 1 in Northern Ireland, 1 in Wales. That's the sort of model we should be trying to get towards. There are definitely people out there who are interested and knowledgeable in other centres that, you know, will come along to some of the presentations and the research meetings and things like that. So that model could definitely be achieved if you like, the political side of it could be persuaded that this was something that, you know, could be supported by the NHS, if you see what I mean. And, you know, that's what I would love to get to. And at the moment, we're sort of fighting a rearguard action to try and defend our, you know, essentially our core clinic. You know, obviously also we have Abbey in London, but we are, you know, fairly thin and, you know, trying very hard to try and maintain the service that we do provide. And, you know, I also mention it because, you know, I think we probably accept, or I accept, that the service that we provide at the moment is not the service that I would like to provide. You know, I would like to be able to see any new SCAD within 6 weeks that's referred. Because, let's face it, you know, people need to be seen sooner, really. And at the moment, you know, I'm aware that the waiting list is running out towards sort of, you know, 6 months at the moment. And that's running the clinic that we're running. So it's not like there isn't demand, you know. So if anything, we should be trying to look to see how to expand that clinical service. But I think, you know, the trustees have a great vision of working with the sort of political decision makers. And, you know, they're very much leading that. And I think that is an important strategy to try to work with. And, you know, we've said, talk to them, and you're very happy to try and support that. And, you know, anything that we can do from that level to get some top-down support will help us. The answer is no. It is different more in respect to the fact that as SCAD survivors you are different from most patients who attend rehabilitation. So again, most of you, or many of you, will have had that experience where you're sitting on a coronary care unit looking around you thinking, I'm not the same as these people. You know, I'm a bit younger than them, or, you know, I'm a bit more female than 90% of them, or whatever it is. And the same applies in cardiac rehabilitation, that really the goals and targets for a SCAD survivor should be different. You know, we should be looking to get you more active than somebody going through rehabilitation. But where Nikki is very helpful is that if your cardiac rehabilitation team wants some advice, she's been very, very good and helpful at giving advice to rehabilitation teams around the country about, if you like, our approach to rehabilitation. Because I think the message for SCAD survivors is that we want you, as far as is possible, to get back to where you were before. And it's not always completely impossible, we accept that, but we know that for your psychological well-being, that getting back to work, getting back to your hobbies and social activities, and getting back to activity, and that may include sporting activity. It may be not running up the side of a mountain, but maybe slightly less than what you were doing before, but still getting back to potentially sporting activities over time. It's important because, again, if you've ever heard Sally B speak, she always says, your head and your heart are linked. And if you stop doing all of the things that you love, and we all sort of love our jobs sometimes, but you know what I mean, but getting back to the things that you do, then actually that gets messed up and it can contribute to not getting over it as well as we would want. So hopefully your rehab team will be attuned. If they're not, we can advise them. And again, we spend quite a lot of time, as I know do the trustees, giving advice, and we have the SCAD email, which is available for people to ask questions and things like that. And again, within our small team, we do our best to try and respond and answer when questions arise about things. So what I tend to say to people is that there are a couple of special groups perhaps. So there are a small number of people who had their SCAD when they were exercising to a high level. So sometimes you might have a scenario where somebody was, I can remember a specific individual who had their SCAD event at the top of the mountain that they just run up. Now, for me, that's probably telling us a little bit about what's provoked the event for that individual. So for that individual, my advice would be to back off a bit. But not to stop, but that's a very fit person. I would say, maybe come back to 90% of what you were doing before. Just not the real top end of the activity. The exercise-provoked SCADs are quite uncommon, and they are mostly male in my experience. Okay? For most people, I would encourage you to get back to full activities, including sporting activities, with that just a little dash of common sense about really extreme things. So I say to people, look, if you're looking at something and you know that picking that thing up is going to make you go purple in the face, then, get someone else to pick it up. If your toddler or your niece or your nephew or your grandchild is crying and needs to be picked up, then pick them up. It's okay to, that's not going to provoke an event. So it's mostly common sense, I think. But I tend to be quite conservative. I'm quite relaxed about people doing things. The evidence that doing activity and exercise is good for the psychological recovery after a SCAD is very clear. The evidence that activity and exercises provokes or causes recurrence or problems after SCAD is not at all clear. And so for me, you go with the stuff that's crystal clear, which is getting back to things that make you feel good are good things to do. On the follow-up questionnaire, it will ask you about what further imaging you've got. So there was a place to put that information. Right now, because for quite a lot of the studies we're doing, we need to know how people have done. So Jenny, who is the other person in the SCAD team, who's our part-time administrator, who again is supported by Beat SCAD. Jenny is currently getting all of those follow-up questionnaires fielded, and they are really key. So anybody who, when you go from here, if someone can put onto your Beat SCAD Facebook page, if you get a follow-up questionnaire, please fill it out. That will really, really help us, because just helps lots of the studies. We need to know what's happened over the last few years. If you've registered onto the study, then you should get a questionnaire. Post-SCAD chest pain is very common. In fact, it's almost universal. There are some lucky people who get none, but they are the lucky ones. The majority will get some post-SCAD chest pain. Admissions to hospital with post-SCAD, when I say chest pain, I should also say that it's quite variable from person to person what your pain is. Some people will have very variable symptoms, some people will feel breathless, some people will just feel a weighty feeling it, but I'm talking about chest pain in the broad sense, right? So readmission to hospital with chest pain after SCAD again is very common. What do we know about this? The first thing to say is most people, not all, but most people, their post-SCAD chest pain is different from the pain that they had at the time of the event. Or it can be distinguished when you start to think about it. That's not always the case, but I think it is the case in the majority of patients. That's the first thing to say. The second thing to say is that post-SCAD chest pain does not, in my experience, herald somebody who's going to have a recurrence. It's part and parcel of the recovery process. I don't know why it happens. It's part of the healing response of some sort. We sometimes talk about vasospasm, or we talk about the nerves around the heart, but that's a bit of flannel. We don't really know the answer, right? But it definitely happens. One thing that I can say from experience is that it seems to get better. Sometimes it takes a year or 18 months. Sometimes people will still have a little purple patch or two after that, but it does seem to improve over time in most patients. So other associations. So one of the challenges with a condition which is uncommon or less common is that when it occurs with something else which is uncommon or less common, people tend to put them together. And the SCAD literature does this a lot and says, well, this person's had SCAD and also has, one eyebrow, and therefore one eyebrow is definitely a causal relationship between, And so there's a lot of this in the SCAD literature. And I think we have to take these things with a pinch of salt and actually base the sort of thinking around the data that we gather. So the specific things that you mentioned there is not something that I see commonly in the registry, okay? I think somebody on the online questions asked about atrial fibrillation. Atrial fibrillation may be a secondary cause. It may result from the heart being injured and damaged, but is not necessarily something that we're seeing as a previous association, more commonly. But there are going to be things, and there are one or two interesting things that are coming out from the genetics, where we say, well, that's kind of interesting. There's a gene there that is also, I mentioned the gene that we have that's also already been linked to some other things, and we're seeing some links like that. And those are things that we need to finish off, we need to validate, so that we can come back to you and say, actually, this is definitely something which is a clear-cut association, rather than it's been linked in a person, it's been published in the literature as a single case, and therefore it starts to sort of become an association when actually it's a coincidence. So not those things, but there will be others, I think, where there are some interesting links and associations with particularly, one or two conditions that have genetic associations. Some of which we know already, right? So your vascular Ehlers-Danlos syndrome, your Marfan syndrome, your connective tissue disorders, some of those things we already know do have a link and association with SCAD. Yeah, so DeLuca, who is working with me on other matters at the moment, is specifically doing a study to look at patients in this context. So he's interested in patients who had cardiac arrest at the time of their SCAD. He's also interested in patients who have defibrillators now to try to understand what data can we get from those defibrillators and is it helpful and so on and so forth. To answer your question, when you have a heart attack, essentially what happens is the heart, for a period of time during the heart attack, becomes electrically irritable. The fact that the blood supply to the heart cells is impaired, the heart cells themselves, which are, the heart's an electrical organ, that's how it pumps in its synchronized fashion. But what happens is when the blood supply is limited, the electricity in the heart starts to get irritable. And in some people, unfortunately, it goes completely haywire. And that's what happens when you have a cardiac arrest. The electricity in the heart suddenly, essentially, just becomes completely random and disorganized and stops the heart from pumping. And when that happens, obviously, we do the things that we do in terms of defibrillation to restart the heart. The important thing about this, though, is that once the blood supply problem to the heart has been sorted out, either through time and healing or through stents or whatever the treatment strategy is, that risk for most SCAD patients then goes back to baseline and the same as the population. So just because you had a cardiac arrest at the time of your SCAD does not mean that that risk remains with you. There are a small number of SCAD survivors who have very big injuries and scars on the heart, so those at the, if you like, the top end of the injury scale, who will be at higher risk, and it's those patients that we would normally think about in terms of defibrillator therapy. But defibrillators are something that should be limited to those patients who have very significant heart damage to protect those damaged hearts. But patients who've been unlucky as yourself to have a cardiac arrest either out of hospital at the time of the SCAD event or in hospital during the process of the care that you have, those patients are not at continued increased risk and so don't require defibrillator therapy necessarily just on that basis. We don't completely understand how this links. So Rob did some very nice work looking also at the little tiny vessels in the wall of the artery, and they didn't seem to be more frequent. So it's not a density of microvessels problem, maybe it's a vulnerability of microvessels problem. But these things are really more about us as researchers and scientists developing hypotheses so that we can start to think. So if I start to think to myself, well, maybe it's a microvessel problem, and then I go to the genetics and I find a gene that's expressed in microvessels, and I go to the blood sampling and I find that there's a protein there that comes from microvessels, then you can start to hang things together as to how this process might work. The most common cause for bruising in SCAD survivors is, of course, going to be the treatment that you take in terms of aspirin and clopidogrel and those types of drugs. So those are anti-platelet drugs. Platelets are the little sticky things in the blood. So if you inhibit those tablets, of course, you're going to get more in the way of bruising. So no, I don't think if you have bruises that means means that you're at particular risk or more vulnerable. Can you become an organ donor? I don't see why not. So the organ donor services will make their own decisions. My guess is that cardiac transplantation probably wouldn't be an option, but there will be many other things that will be absolutely fine if you do wish to become an organ donor. How long does a SCAD take to heal? It is variable from person to person. 3 to 6 months is what the data suggests. Now, 3 to 6 months is what we're looking at in terms of when the lumen expands back up again. Okay, as that bruise and bleed in the wall heals, the actual healing process, if you like, at a microscopic level and in terms of the symptoms that we talked about in terms of post-CAD chest pain, I think takes a much longer period of time in many people, and I mentioned 18 months to 2 years from that perspective. So research links atrial fibrillation I talked about, fibromyalgia, very common association after SCAD with those kind of symptoms, fibromyalgia, chronic fatigue, those types of things is something that the Dutch group have been working on and we're writing a paper on at the moment. So there'll be a little bit more data to come out on that fairly soon. SCAD and exercise, I think we talked about that. Generally speaking, I am pro-exercise. Don't, run up the side of a mountain or, do something crazy, but, get someone else to raise money for Beat SCAD for doing that while you cheer them on at the line. But yes, most things are fine. Genetics, are my daughters okay? At the moment, the data suggests that we don't need to screen those daughters. I think in 12 months' time, the picture on SCAD genetics will be very, very much clearer than it is today. So definitely a space to watch, but it's not something that I would be sitting worrying about at the moment. The data does not suggest that this is a strongly familial condition, that it runs in families. FMD, trying to find, do you know the research into FMD is trying to find markers of impending issues. So I think hopefully I made it clear that FMD for me is something that I'm reasonably relaxed about. I might tell you that you have it because FMD is a description of what the arteries look like. But I'm not, I barely think that most FMD is a pathology in SCAD, okay? I'm sort of almost more interested in the other abnormalities in the arteries elsewhere in the body, if there are dilations or other dissections elsewhere. We are, dedicated to continue the work on the research, and I think it's going to be a really exciting year this year in terms of the progress made, and as I said, that's all supported by Beat SCAD and the amazing work of your trustees. So that's it from me. Nice to see you all. Hope to see you maybe at the conference in June.